Hello, my name is Dr. Nigel Watson. I'm a GP in the New Forest and Chief Executive of Wessex Local Medical Committee. As part of the partnership review, we've looked closely at the issues to do with workload and workforce. This blog is split into two parts and focuses on the workforce. To help manage the current and future workload, there needs to be an increase in the number of full-time equivalent GPs, and also in other clinical and administrative staff working in general practice and primary care. There also needs to be more effective collaboration with others who work in the community health services locally. In 2016, the government committed to recruiting 5,000 more GPs, but despite significant efforts to achieve this, the trend has been in the opposite direction in terms of GP partners and salaried GPs. However, this year we have more doctors entering GP training than ever before, and the staff numbers providing direct patient care has also been increased. The GP vacancy rate is variable but significant in some areas, and repeated surveys have shown an alarming number of GPs who intend to leave the profession prematurely within the next 5 years. Looking at the GP workforce, we know that the number of GP partners is reducing. This is caused by the difficulty in recruiting younger partners and also retaining GPs in the latter part of their career. It is often said that younger GPs do not want to become partners. During the course of the review, we've talked to a number of younger GPs and found this not to be the case. Many do not want to become partners initially after finishing their GP training, but would consider this in the future, and their desire to become a partner increases with time. And many have said to us that there are things that would make them more likely to consider partnership. This included reducing the financial risk, confidence that the partnership they were joining was stable and well led, and that they were joining a good team, and they could see a clear and positive vision for the future. If more resources were to go directly to general practice and primary care, there would be the ability to give more time to manage complex patients, have protected learning time, and reduce the number of patients an individual clinician consults within a day, and make the working day more manageable. In the past, many doctors chose general practice as a career because of the flexibility it offered, but as the workload for practices has increased, some of the flexibility has gone. The sessional workforce, both salaried GPs and locum GPs, will continue to be a vital part of the flexible and responsive general practice that we know today. But partnerships looking towards the future should consider options for reintroducing flexibility to the working day that could enable them to recruit and retain a broader range of partners and staff. More GPs work less than full time because of family commitments, and these do not always fit into the traditional working day of a practice. Some practices are looking at more flexible options to recruit partners, to add vital capacity, but also to future-proof their practice, as many of these GPs will increase their hours when family commitments change, especially if the working environment is good. This is not always easy for smaller practices, but may be facilitated across a larger network. When we look at the traditional partnership structure of general practice, this doesn't always meet the aspirations of younger GPs who are looking for career progression. And perhaps we should look at the other professions who work as partnerships, such as accountants and solicitors. And if you look at our case studies, you will see more details into these structures. If we are to increase the number of GPs, then we need to make general practice a better place to work. We need new initiatives at various stages of the career, and this would help both with recruitment and retention. We also need to make it easier for GPs to return to the UK after working abroad. And we must address some of the issues such as pensions, as this should be seen as a benefit for general practice, and all too often now it's perceived in a negative way and it's having unintended consequences. After completing GP training, we know that some will opt to go straight into partnership, and others may opt for a salaried role. Some also opt to become locums, as this can be seen as offering greater flexibility with less financial risk and a greater ability to manage their workload. It is true that some GPs have no plans to join a partnership, particularly when the risks of partnership are viewed as being greater than the benefits. The review has concluded that if nothing changes, then the ability to recruit partners in the future will become increasingly difficult. However, the review has also been told by many GPs early in their career that they do have an interest in partnership in the future, but they may want to approach this in a different way. They would like the opportunity to work in different practices, to experience different partnerships, before they decide which one they would opt to join. They would also like to have time to build their experience and develop a significant area of clinical expertise, learn more about the potential opportunities and benefits of partnership, and gain more knowledge and experience of the business skills that are necessary for partnership. While these kinds of opportunities have begun to be offered in some areas, they are not yet universal or comprehensive. We are therefore recommending that newly qualified GPs should be able to gain experience as a valuable employed member of the practice team in a supported environment, and these new posts would be called primary care fellowships. They are not a compulsory extension to GP training programs and should not prevent qualified GPs from becoming partners early in their careers, as they may acquire the relevant skills and competence through other experiences. But this route would represent a clear alternative option to a more traditional partner or salaried role. The primary care fellowship should be offered for a meaningful period of time, such as an initial period of 2 years commitment, and available early in the GP's career, when individuals may be at the greatest need of support and guidance, and provide an attractive salary and incentives. These fellowships should be based in each primary care network and funded as part of the long-term plan for the future of the NHS. Timing to introduce these posts should be linked with the development of primary care networks. Consideration should be given to extending the scheme beyond the early career GPs to other professions and other points in the GP career in due course. Recent evidence published by the King's Fund has shown that many GPs at various stages in their career wish to develop a portfolio career. Currently, there are well-developed opportunities in education and commissioning. More opportunities now need to be created and funded in clinical areas for the establishment of mid-career GPs, which would support general practice and also be based in the community. These could include specialties such as diabetes, respiratory care, dermatology, frailty and musculoskeletal conditions. These posts should be accredited in line with the GPs with extended scope of practice framework, which is being developed by the Royal College of GPs. This will need to be supported and appropriately funded. These posts should be primarily based in primary care networks with links to specialist colleagues. Specific training on leadership and quality improvement should also be provided to support GP development throughout their careers, funded by the NHS Leadership Academy and Health Education England. This should support the sustainability of the GP profession and the ongoing involvement of primary care and general practice at system level. It should also provide further career structure and options for mid-career GPs. GPs in the latter part of their career are often very experienced and have gained significant wisdom. However, they may not be able to or may not wish to work at the same pace in terms of delivering direct clinical care as they did when they first qualified. This is particularly the case when experienced GPs are holding a more complex caseload or haven't taken on greater responsibilities within their practice, partnership, or at network level. Building on the successes of the existing GP retention scheme and the GP Career Plus scheme, experienced GPs and partners in general practice should have access to a broader range of opportunities funded as part of the long-term plan for the future of the NHS. This could include mentoring and supporting staff on the primary care fellowship scheme, or providing specialist services such as frailty clinics, managing complex patients, managing care home patients, or being part of a locality-wide home visiting service.